Yeah, we are live now.
Good evening. Welcome all of you for this OBGYN Pulse Midweek webinar series. And we'll have two excellent speakers today. And Dr. Sheila ma'am, you all know she'll be talking on PPH management. The other one is Dr. Shruti. She will be talking on cancer cervix screening from PAP to HPV. And I'm just sharing. Thanks to all the chairpersons who have readily agreed to be the chairpersons for the webinar, all the presidents and secretary. We'll start now with the prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, Sagiti. We'll be starting our first session. I would like to introduce all the chairpersons. Dr. Mangala Devi. Yeah, Mangala is done her ABBS from Ramaya and MS from Davangere. She's a director Smile Baby Multi-Specialty Hospital. She's a current president of Bangalore Society of Obstetrics and Gynecology. And she has been a treasurer and EC member of IFS Karnataka, and where several state and national conferences. She was a speaker and has presented various papers. Welcome, Dr. Mangala. Can I have the next slide, please? Yeah, Dr. Lata is the medical director, Hiriyur, Chitradurga district, and she is a fellow in fetal medicine and trained in laparoscopy. And she has conducted several national health programs and areas of interest is safe motherhood and fetal medicine. Welcome, Lata. Dr. Uma, and she's the HOD OBG Bidar, and she's the president of Bidar Society, and she's the instructor for ECLS training for medical students, and received the Best Doctor Award from Bangalore, and Sarvotam Seva Prahasti from Government of Karnataka, Shri Sakti Prahasti from Kalaburgi, and Aspiring Women Award 2021 from Bidar, and lot of appreciation certificate from Karnataka State Government Employment Association and IMA and Rotary Club of Bidar. Welcome, Uma. And Srilata, she's a laparoscopic surgeon, infertility specialist, and she's an infertility consultant for the past 15 years. And she's also done a diploma in ultrasound from Iron Donor School of Ultrasonography. And she's an associate member of the Asian Society of CME. Welcome, Dr. Srilata. And Sumaya, she's a consultant for the past 28 years from Belgaum. She's the medical director and she's the president of the Belagavi Obstetrics Gynec Society. And she's a joint secretary of Indian Menopause Society, Belgaum chapter. Welcome, Dr. Sumaya. And Shailaja, she's the professor under the Department of OBGYN Karnataka, and she's got a lot of publications, and she's a past honorary secretary of BOGS, and she's got various awards in state and international conferences, and she's the president of Bijapur Obstetric Gynec Society. Welcome, Dr. Shailaja.
Thank you, madam. Thank you.
Yeah. Can I please, Shailaja ma'am, can you just introduce Sheila ma'am?
Okay, madam. Send me the slide. Slide is.
It's there, ma'am.
I think, Dr. Shah, no worry. I can proceed with my
No,
talk.
no, no. This is very important, madam. Yeah, Srilata, can you maybe, madam? Yeah, Shailaja ma'am is there. Yeah, madam, can you see, ma'am?
No, I am there, but I want a CV
It's
of
there
Madam
already
Mane, Madam.
projected. Already projected. Dr. Sheila Mane,
No, I am not getting.
not able to see, ma'am.
No, I am not getting.
Dr. Shailaja, ಸ್ವಲ್ಪ
ಹಾ
screen move
okay,
ಮಾಡಿ
okay, okay,
ಹೀಗೆ.
okay, madam. Okay, I got, madam. Thank you very much. Madam is ICOG chair elect and ICOG vice chairperson 23, and vice president of Foxy 2014, chairperson Safe Motherhood Committee 2008 to 2013, president of BSOG 2005 to 2006. President of BMC Bangalore 2019 to 21, National Facilitator Adolescent Health WHO, ICOG Governing Council Member 2020 to 22, ex-President Bangalore Menopause Society, President of ASOF Bangalore Chapter, Reviewer of Yogi, and Faculty FIGO PPH Stimulation. Madam is known by everyone. It is really, madam, it is a honor to me to introduce you. Sheila Mane, madam, I know since long time.
Thank
I
you,
know,
thank you.
madam.
Very nice to
Thank
see
you.
everybody. The,
Thank you, madam.
Thank you, ma'am.
thank you.
Can
So
you
it's
share
nice
the
to
slides of Sheila Mane, ma'am?
Yeah.
Presentation.
Yeah. Thank you, Dr. Vijaya, for this invitation.
Thank you.
And it's nice to meet all the friends as they are chairperson. And one thing I always like in webinar, when the CV is projected in a big hall, you never concentrate.
Yes, madam.
But when it is done in a webinar, I know, and I really appreciate that because you really know the credentials of the person. I mean, see, everyone has done so much work, and you closely observe the screen and you are so much concentrating. And I have seen that, particularly OBGYNs, they are really doing multitasking and everybody's CV is so great. So congratulations to all of you. Okay. And best of luck, Dr. Vijaya,
Thank you.
for your future endeavors. Yeah. So as you it is a very comprehensive talk. So I thought all of us, we know about surgeries and all this. So let me touch upon certain important things which we okay. Society, you will be, no, go to first slide only. Yeah. So all of us, we know the golden hour concept and the best practices for medical management. And we know that whatever we do, know that should happen golden hour, then only we will be able to save the patient, because patient can die in 2 hours. We know that they bleed to death. So the golden hour is very important. Next slide, please. So all of us, we know the definitions, okay? But any blood loss that has the potency to produce hemodynamic instability should be considered as PPH is the new definition. Why? Because particularly in our country, we have small-made women, we have anemic women, we have women with preeclampsia. Now, what happens in these patients? The blood volume is not expanding like in a normal, healthy, pregnant mother. So, if these patients, they lose even 300 or 350 ml, there will be a hemodynamic instability, and that definition is acceptable. Hemodynamic instability should be considered as PPH. So, next. So now there is a big question that can we have PPH? Definitely the answer is no. Why? Because no, there is a limitations of prevention of obstetrics. And I think I really find nowadays that really we have to again enforce about this prevention. Obstetric complications are bound to. Now, when we say prevention, it is not only active management of third stage. When we say prevention means that prevention is there antenatally, intranatally, as well as postnatally. Antenatally, we will have to find out which are the risk factors. Most important is the treatment anemia, because if we focus on that and if we know that there is a case or there are a group of patients who are high risk or they have a medium risk, definitely we will we have to act, whether we have to arrange the, for example, placenta, Vijaya and placenta, etc. So that is prevention. In labor also we will have to see whether it is a prolonged labor, whether there is chorioamnionitis, whether there is misuse of oxytocin. And postnatally, of course, proper management of third stage of labor and the fourth stage, which is the observation. After the third stage, very important, the patient can still bleed. Obstetric complications are bound to happen. Teaching and training will keep coming. Universal protocols are still not followed everywhere. Okay. And another thing in the government public sector, we find there is a constraints of human resource, non-availability of consumable and drugs, unskilled doctors not updated. Forget about unskilled doctors. We have people, those who are not doctors and practicing obstetrics. Various delays still prevail. Still prevail means the people are still not aware. They do not come to the facility, or maybe they have transport problem. And woman is still considered as commodity and her rights are never respected. And there are so many cultural issues. Next. Sorry. But can we have zero PPH deaths? The answer is yes, we can. Because the deaths are preventable. We will have to evaluate the causes from root to roof. Delays have to be taken care of. Now, when I talk about the delays, we'll stress on the third delay because that happens in our facility. And UNICEF had done a study in 6 states and they found in most of the cases, third delay was the cause for the maternal mortality. Now, why third delay was the cause? Because the cases which are brought to the facility are already a morbid cases. And naturally, what happens if we do not attend them in triage immediately, third delay will kill the mother. Non-clinical component should be focused on. What is non-clinical component is the that is, you have to have a team, proper communication, proper referral linkages and all that. System integration and readiness of facilities is very important. Still today, the facilities are not ready. If I ask in any meeting that can you raise hands, how you have a balloon or an anti-shock gun, few hands still go up. Universal evidence-based clinical care is not there. Feedback loops to a PPH, any problem, we should have a feedback debriefing. And depending on that, we should do the quality improvement and the policy maker involvement and advocacy. So the clinicians will have to take the initiative to do all that and then involve the policy maker. Then we can have zero deaths due to PPH. All the more when the incidence of cesarean section is on the rise, and we know the incidence of postpartum hemorrhage is higher than vaginal delivery. It is 6 to 8%. With increasing incidence, we will have more and more cases of postpartum hemorrhage. Next. Next slide, please. Now, the prevention and treatment of postpartum, where do we go to next? Now, maternal mortality and morbidity depends on prevention and early death. We all of us, we know. And it would be a slippery slope death zone if we do not prevent it or manage. So we can see in this diagram, okay. So the determinants of outcome in confidential inquiry, the patient's blood volume, which I told you, the pre-delivery hemoglobin, which is very important if she is anemic, prevention and early treatment of coagulopathy and severe shock, where 40% of blood, so we will have to see that we manage her so aggressively and prevent that coagulopathy because that time it becomes a irreversible shock. Now, pre-delivery hemoglobin is so important because anemia is one of the main reason. And now even the recent studies have come, the recent advances that in low income countries, why the incidence of PPH in developed countries. Yes, it points towards anemia. Now, why anemia gives rise to more bleeding? One thing is the patient's heart rate is more, the stroke volume is more, placental sinuses are more, it's more. There is a atony. Second, because of the anemia, the RBCs are lesser in number, the lamellar flow is disturbed, there are no platelet periphery to block the vessel. There is increase in viscosity, so the she bleeds more. And fibrinolysis, the clot undergoes early dissolve. It dissolves early. There's early fibrinolysis, and there comes the role of tranexamic acid. And fifth one is iron deficiency anemia also makes the myometrium weaker. So there is a atony. So so many things contribute for bleeding in patients of anemia. Okay. So this is the that if we don't act, the patient can go to death zone. Next. Next slide, please. And as are aware, tone most commonest, 70%. Then comes the trauma. Then comes and thrombin is only 1%. But now, with increase in the incidence of hypertensive disorder, we find that DIC is becoming. Now, all of us we know that is tone could be because of over. There could be infection or anatomic distortion or anomalies. Trauma, we know during labor it can happen, instrumental delivery, even a trauma during cesarean is also responsible. A deeply engaged head or obstructed labor when we are trying to deliver, extension of the angles, broad ligament hematomas, tissue, retained placenta, and now addition to this is the adherent placenta. We know, all of us, we know that abnormal placentas again become thrombin, which is 1 to 2%, that is due to abnormal coagulation. Next. Quickly, you can change side. Now, secondary PPH also need to be taken into consideration because if the products are retained, it can lead to that infection, endometritis. Okay, trophoblastic breakdown of uterine wound. So we have to really look at that why there is secondary PPH. Whatever method we are utilizing to close the uterine wound, because nowadays they say there is no need to lock. If we lock, we are making the wound weaker because what happens is the blood supply gets altered and it can cause gangrene of the tissues and the tissue healing can get affected. Chronic subinvolution of the uterus could be because of the other causes like infection and all that, and AV pseudoaneurysm of the artery. Next. So diagnosis of first, what is important in golden hour is, yes, visual estimation of blood loss is everyone practices, but that may go wrong because it is not standardized. Direct measurement with a brass wheel or any collection canister you have, and you have to calculate. Shock index is heart rate divided by systolic blood pressure. During pregnancy, it is 0.9. If it goes beyond, patient is into hypoglycemia. First hour need to be managed. Rule of 30, we have to see. What is rule of 30 again? Increase in the heart rate by 30, increase in the respiratory rate by 30, output, urinary output less than 30 ml per hour, and patient's hemoglobin hematocrit dropped by 30%. That means this patient lost 30% of blood. And if she has lost 30%, she class 3 hemorrhage, where transfusion. And of course, signs and symptoms. Depending on the blood loss in class 1 and class 2, if the patient is in agony, shock index will help you. But in class 3 and class 4, in class 3, there will be a hypotension. In class 4, patient will be in shock. Next. So, of course, you need a multidisciplinary approach. So, effective management will depend especially on massive PPH requires a coordinated multidisciplinary team. Each member has a specific responsibilities. Team includes obstetrician, nurses, midwives, anesthetists, intensivist, blood bank, hematologist, support staff, with the obstetrician being the leader. Now, if you are in a smaller nursing home, you may not have all this, but you will have to prepare your own team. I know now Tamil Nadu has become so strict, every maternal mortality is taken very seriously. So you need a backup system wherever you are practicing obstetrics. Next. So golden hour is the first 60 minutes from the time of recognition of PPH, most crucial time to achieve maximum cervical resuscitation must start in golden hour. Next. Now, the impact of treatment delay of severe bleeding and tranexamic acid must be given. Why they have to give tranexamic acid early? Because immediate treatment, you will get 70% improvement in survival. For every 15 minutes delay, there is a 10% decrease in 3 hours, there is no benefit. So all of us, we know about the tranexamic acid. I will also talk when I tell you about the emotive trial, that you have to give it as early as possible. You know that your patient is bleeding. In spite of giving oxytocin, you will have to give her tranexamic acid. Next. Now there is a PPH bundle approach. Now the purpose was prevention and recognition of PPH, first response to PPH and response to refractory PPH. Now there are several bundles, right? But the two universally accepted and being in are the emotive. I will come to that, and the PPH emergency care bundle. So these are the two bundles. Next. So these are the all evidences put together with an important cause of concern, which works in all healthcare setting, in all income countries, and in wherever you are, urban, semi-urban, rural. And universal approach to reduce the case, morbidity, and fatality with overall reduction in maternal mortality and morbidity. Okay. So this type of chart we should be, sorry, having in labor room. So this chart is showing whatever IV line with a big bore cannula, pH tray, or your crash cart should be ready with a isotonic saline. Compression, you do biomedical compression, you remove the clots, you see to it that you give oxytocin and the bleeding is controlled. Okay, immediately apply the anti-shock garment that comes in. Please. Sahit can do it faster. Sahiti, please change the slide. Yeah. So this is the slide showing the clinical and non-clinical component. And I will not talk much about non-clinical because that itself is a different topic. But non-clinical is that I told you in brief earlier. So this bundle has two packages, that is training package online, and there is a module or offline implementation package. So it also consists of training at the periphery. Next. So this discussed in brief earlier. Next slide, please. Next.
Next slide.
So first response, uterus contracted or not, because it could be traumatic, it could be retained tissue. Have to massage and see that the uterus is contracted, which will help to express the clots. Then you start the IV fluid. Now, how much IV fluid to give is very important. Usually we say 1:3, 500 ml, give 1.5 liter. Okay. Your big bore cannula, which is usually 16 in number, you will have to draw the blood for investigation and arrange the blood as early as possible. At least arrange it once you have diagnosed. You may not order. And you give the uterotonics, the medication. What? Okay. The use of methyl ergometrin is and PGF still not controlled. Tranexamic acid, we know women trial, 2017 trial, we have to give as early as possible. Now we have TRAP 2 and TRAP 1 and TRAP 2 trials also. Have come. TRAP 1 is use of tranexamic in vaginal delivery, which they did not find mild. But in TRAP, where the prophylactically the tranexamic did find that there was an improvement because the quantity blood lost was definitely lesser compared to not giving prophylactically. So it does play a role. So this is the first response. Next. Next slide, please. Sahiti.
First three.
First response, empty the bladder, check for tears and repair.
Greatest.
Somebody has to, Divya.
Divya.
Yeah. Please mute. This also I discussed. Go to next slide. Go to next slide.
Next slide, Sagiti.
Yeah. This is the refractory PPH. Now compression.
Previous slide.
Concentrate, Sahiti.
Previous slide. Previous, ma.
Previous, not ahead. Go back.
Go back one more. This one. Yeah.
No, go back. Huh? So compression manuals, bimanual compression, abdominal aortic compression, and you can also use uterine balloon tamponade and the non-pneumatic anti-shock garment as soon as you diagnose PPH must be applied. And I think we are really of Tamil Nadu, the first state to bring garment at every facility. Okay, and that has shown us the results. Next slide, please. Next slide. I will not go into the detail. You can have a condom tamponade, a Bakri balloon, a LRV. We have all sorts of balloon which can be used. Okay, next. Now we also have hemostatic packs. You know, earlier we used to use the conventional pack, which is not being used anymore. What is e-motive is the early detection of PPH and use of bundle treatment to lower the risk. Okay, so here we can, if we act early, definitely laparotomy can be avoided, death from bleeding can be avoided, and they found that it was very useful. So that was the e-motive trial. Okay, next.
Next slide.
Next slide, please. E-motive stands for evaluating medical treating PPH innovation was established therapies, aiming to compare the innovative therapies with established also. Next slide, please. Go on, changing quickly. When I say next, you should change it immediately. Sahiti, please. Next slide, please. So it
was network issue. So
detection of
something is
PPH.
happening. Yeah.
The WHO. Hello.
Yeah. Is this correct slide, ma'am?
No, go back to previous slide.
Okay,
I
ma'am.
think this is the
No,
one,
go
yeah.
back to previous.
This one correct, madam.
Yes. From here, now you go ahead. The calibrated drape for early detection of PPH, the WHO first response treatment bundle. That includes M is for massage, motive, O is for oxytocin, T is for tranexamic acid, IV is for intravenous, and a process for examination and escalation. So the last T is for escalation. Next slide, please. My laptop also gave trouble today only. Okay. Now this was done where it was showed that there was 60% lower there was composite of severe postpartum hemorrhage, laparotomy for PPH and maternal death from postpartum hemorrhage was assessed, and after vaginal birth across secondary level hospitals in Kenya, Nigeria, South Africa, and Tanzania. Their e-motive trial happened. Next, please.
Detection massage.
Whether she has a network problem. So this is the e-motive chart. Okay. So this is the e-motive chart. All of us, we know that you will have to assess the blood volume. So early detection and a trigger. Now the trigger starts early. Every observation is once you find that there is a 300 ml blood loss, your trigger should start. You need not wait 300 ml. And you will have to observe the tone every 15 check the blood pressure, okay, for first hour every almost 15 minutes, and then you will have to maybe if the patient is not bleeding. So other criteria are clinical judgment, blood loss 500 ml or more, blood loss 300 ml or more, plus one abnormal observation means her is there or there is a fall in BP. Massage of the uterus for 1 minute, start 10 units, international units of oxytocin in 200 to 500 ml of crystallite over 10 minutes, plus a maintenance dose again. I mean, you have given either, now we don't give IV, we give IM, and add 20 units again to 1000 ml of saline over 4 hours. Or you can use misoprostol per rectally. Okay. Tranexamic diluted in 200 ml of crystallite over 10 minutes. And IV fluids in addition to the infusion should be given if clinically needed for resuscitation. You may require a second IV access. And then ensure bladder is check for tears and with an internal examination and placenta for completeness, and escalate if bleeding does not stop after response to your you are unable to identify or manage the cause of. So that is how you will proceed. Next. So these are the highlights now, which I have already told. Again, go to next slide, please. Tranexamic acid also we discussed. Next slide, please. We can repeat it after 7 to 8 hours. Next. This is the shock index. Okay. So if the shock index is 0.6 to 0.9, the patient blood loss may not be more than 500 to 700. Loss of blood volume is 20%. If it is 1, has already lost 1000 to 1000, is 20 to 30% blood loss. Shock index 1.5, 1500 to 2500, 30 to 50%, and more than 2, your patient has lost almost more than half of her blood volume. So shock index, a simple clinical finding, can tell you about the loss. Slide, please. Now, shock index more than 0.9, there is a risk of transfusion. More than 1.4, need aggressive therapy. More than 1, high risk of adverse maternal. So you will have to be, you can assess from the shock index that what is the condition of your patient. Next. Rule of 30, we already discussed. Next. She is moderate to severe shock. Next. This is the chart. This is the which tells you about the patient's. So if you see class 1 and class 2, there is a slight fall in BP in class 2 in spite of 1000. Okay. And there the shock more than 1. That means what? The degree of shock goes to grade 3. Okay. So you will have to be really very, very careful and how, in what condition she is, and you can judge by this. Next. This very simple test, point of care clot time test of whole blood. Point of care test, if you hi-fi institution, they have TEG, thromboelastography, rotain, that rotational thromboelastometry. But this is a simple test that I think as a postgraduate we used to do. So take a blood sample, 5 ml of whole blood in a plain glass tube and note down the exact time. Do not add any additive. The tube is held in a closed fist to keep it warm, and after 4 minutes, the vial is tilted every 30 seconds to observe whether a clot has been forming until the blood clotted. And the time is noted time elapsed in calculating. You will have to observe. Next slide, please.
More than 10.
If it is more than 10 minutes, that indicates there is hypofibrinogenemia and there is a need of supplementation of the same. Now, usually you will wait for 8 minutes. You know that 8 minutes have passed, still it is not clotting. You know that the patient has lost all her coagulant factors and mainly fibrinogen. So you will have to make arrangements either or for cryo or FFP. Next. I wish. Next slide, please. So this is thromboelastometry, which is very, very useful. But today it is only in places where they are doing liver transplant, and very few blood banks have it. Next. Next. I don't know, Dr. Vijaya, we can ask her later. It's available. Next slide, please. So the calculated loss, we know that this is like that MEOT chart, and if you have the MEOT chart, because your nurses will record the findings depending on that. So if it is included in your case sheet, it becomes very easy because it is modified early obstetric warning score and actions are by. If you find your patient is in red zone or brick red, definitely your patient is in a state of shock and you will have to take the measures. Next slide, please. Any problem in the slide, Sahiti? So coming to management of PPH.
Yeah, I have already changed, ma'am.
Okay.
I know, but it is
Little lag is
Actually, there
there.
will be 2 seconds delay,
Yeah.
ma'am, because I will be changing. Your net also should be good. My net also should be good. So
Okay, the projection takes
yeah,
time.
it will take 2 seconds.
Okay,
delay.
fine. No worry. So all of us are aware about now here HABC means hemodynamic control first. Then comes the airway, breathing, support and circulatory support, fluid resuscitation. And depending on the shock, you will have to go for blood transfusion or massive transfusion and management of the cause. Then stepwise initial resuscitation steps. Next. So it is very important. Now, with we have a leadership development initiative with FIGO, with Foxy, and I was develop these charts. This is the management delivery, and we have a separate charts now for vaginal delivery and for cesarean. Why? Because it is very important. Because after you may take time surgery. So if there is a massive blood loss, you will have to arrange for the massive blood and blood products. Immediately in major PPH, you should have 2 units of PRBC. PPH, all 4 you will order. Platelet could be SDP if it is SDP could be 1. And cryoprecipitate, fibrinogen and factor 7 if available. So all the management we have discussed about the medical management, and stabilizing the hemodynamic equally plays a very important role. So if you have a it is better to call your anesthetist or your intensivist, okay? And if find that it is a severe postpartum blood ready. Now, suppose if we are working in a very busy obstetric unit, it is always good to keep OBGYN blood ready, because that will help to save the patient, because your patient is already in a state of shock. And always please. Surgical intervention could be MRP, surgical repair of a surgical that is genital tract trauma, and tamponade and all that. Persistent bleeding, you will continue to do aortic compression. I will tell you, I must share with you all my practical experiences, that if the patient is bleeding and you are arranging all this, we must do this, it will really prevent the blood loss. Give massive transfusion, and meanwhile, if you find your patient continues to bleed, you think of a surgery. Now, artery embolization is not available everywhere, and it should be done only if the patient is hemodynamically stable. Now, fibrinogen is available. Now, in my experience in Karnataka, now we are propagating, because in periphery, there are only blood storage units. They don't have the products. And if there is a massive bleeding, it is very difficult to get the blood products in time. At least if you have fibrinogen, we can give immediately 2 grams. Okay. The dose is milligram per kg body weight, but 2 grams. Okay. And is not available everywhere. So, in case of massive bleeding, there is an indication for factor 7 also. Next. Next slide, please. Yeah. Following cesarean section, we know that we will adopt to surgery earlier. There we don't have to wait and see. Same thing follows, but you may go for compression suture or stepwise devascularization or internal iliac artery ligation, and last and immediately simultaneously you are also correcting anemia, giving the blood and blood products. Okay. And also you can use fibrinogen as well, and monitor the patient, get the investigations done, because you will have to know in what stage whether she is going in for coagulopathy. It is very important to manage the patient, Next slide, please. Recently, we had a case of plasma percarita, and so well on table, in spite of putting the bulb, common iliac and internal iliac, the patient was bleeding, and transfusion was given on table. And at the end of the procedure, the ABG was our patient has maintained it. Okay, she had not gone into acidosis. So that is the real management, and that is why you need a support system. You should not allow your patient to go in for that triad. Next. Hypothermia, acidosis, and DIC. So all of us, we know about this now. Recently, now there are some we use oxytocin. Okay. And we'll have to be very careful when we give it rapidly, because it can cause hypotension, okay, and water intoxication. So Now, recent advances is saying that you have given all the Oxytocin, but if your patient is in shock, if she is hypotensive, don't give oxytocin. You can switch over to carboprost, you can switch over to ergometry because and that is the reason we don't have to go on giving oxytocin. Okay. That is the recent thing which I want to share. Yes, of course, you will give misoprostol, tranexamic acid, and all that. Again, in this table, we have mentioned about factor 7. I must share Bihar and Rajasthan state have factor 7 available in every government facility. And now when they have the cases of placenta previa or other than placenta, in case of severe PPH, they do give blood transfusion side by side, but they have saved patient by giving at least 2 milligram of factor 7A, recombinant factor 7. Next. Next. So this slide is very important, Suppose you have blood volume. Estimated blood volume is 65 ml per kg for an average female. Blood loss will be estimated blood is equal to hematocrit initial plus minus hematocrit final divided by hematocrit initial. So for a 50 kg woman, it will come to allowable blood loss will be divided 3250 divided by 40 will be 812. That means this patient who is about average woman can tolerate only this much. If she has lost, definitely hypotension or hypovolemia. Next. Weight loss does not give the exact amount of blood loss, and estimation of blood loss after birth quantified if you do is more useful. A clot conversion factor is used, which ranges from 1.3 to 1.5 depending on hemoglobin. Conversion factor of 1.4 for hemoglobin ranging for 9 to 11. That means if it's anemic, it is not 1:1. It is 1 to 1.4. Calculate if and has next.
We cannot hear you, ma'am.
Always happens. So your
Vijaya, ma'am, are you able to hear?
She lost a connection. There's some problem with the net, I think, ma'am said. That is where that volume. Yes, ma'am. Unmute, ma'am. Unmute.
yeah, sorry, yeah. If it is 1000 to 1000 ml, 1500, urgent cross match 6. You may give only 2, but cross match 6. Okay. And it should come within 30 minutes. More than that, sometimes if you find your patient is continuously bleeding, it's very urgent. 10 minutes you may not get it. So give group type specific also. And if the patient has lost more than 50%, give first O negative and then you ask for group specific. Next slide, please. Next slide. So now we talk about hemoresuscitation. Okay. If hemodynamic balance is not achieved even with transfusion of 2 liters of crystallite, in an ongoing hemorrhage, 2 units of PRBC can be given even before lab parameters are available. And subsequent transfusions are based on control of bleeding, clinical evaluation of hemodynamic status, and lab results. Okay. So don't try to give too much of crystallites also, because that will pop the clot and which will cause dilution. And that can lead to dilutional coagulopathy. Next. Next slide, please. So what is massive transfusion now? It is defined as if more than 10 units of PRBC is given in 24 hours, in 6 units in 6 hours, and more than 5 units in 4 hours. Or loss of 1 blood volume within 24-hour period, okay, and loss of 50% of blood volume within 3 hours. Or if the patient is bleeding in excess at a rate of 150 ml per minute, that means your patient is having massive blood loss. Next. So you will have to give massive transfusion. Now, all of us, we know the ratio which we are following is 1:1:1. And when we are giving this, what values we have to achieve is hemoglobin between 7 to 9, INR 1.5, platelet count more than 50,000, and fibrinogen should be maintained more than 200 milligram per deciliter, and then only the patient will not bleed. If it is less than that, patient will continue to bleed. Next. Next slide, please. Now, 1 unit of PRBC will raise hemoglobin by 1%. 1 unit of platelet concentrate will raise by 5 to 10,000 microliter. And 1 unit of FFP will raise clotting factors by 3%. And 10 units of cryoprecipitate will raise fibrinogen by 100 milligram per deciliter. Okay. So it is very important that when you have a massive hemorrhage, nowadays there is a shift and you are giving FFP. Already, you know what we say, that we don't want blood pressure to be 110 or 120, because you need a hypotensive only. Patient blood pressure should be maintained around 90 so that the clot will not pop. If you are giving fibrinogen, it's a 200 ml volume. And how much fibrinogen contains, how much FFP contains, how much fibrinogen? 2.5 gram. If you give cryoprecipitate, it contains 10 grams per liter. And if you give fibrinogen concentrate, it contains 15 grams per liter. Okay. And now, as you have already given the IV fluids, you are given the PRBC. If you go on giving FFP, you are diluting the blood. You are diluting the blood and fibrinogen level will drop because the volume is more and the patient will. So now the shift is early cryo. And we know 1 pool of cryo is 5 bags. If you give 10, you know, we said that it will increase it by 100 milligram per liter. Okay, per deciliter. So it is better to give cryo or give fibrinogen concentrate. Next. Next slide, please. So this is that. Sorry, cryo even 15 gram per liter and fibrinogen, yes, same. I told you. Concentrate will increase by 20 gram per liter. Next. So this is the fibrinogen concentrate. There are 2 companies. No, we are not promoting anybody, either Reliance or Intas, and we are using it. Very helpful in abruption, particularly because we know fibrinogen is low. We can give, and it has to be given in early stages only. All of us, we know that. Okay, not in a later stages. And it can really help to increase the fibrinogen level. Okay, so if we give it, dose is 70 milligram per kg body weight, but at least give 2 grams. Okay, it may not be available. So now all of us have started storing it because in case of an emergency, it really helps. Okay, next. Recombinant factor as an early urgent therapy when standard uterotonics have failed. Doses is 50 to 90 microgram per kg IV bolus. Okay, as I told you, when we look at the chart now, we have given 666. We may give again ultra 666. Still you find your patient is bleeding. But by this time, you have also given cryo. Because when you give 6 PRBC, 6 platelet and 6 FFP, you give 10 cryo. And now, when you want to give factor 7, the platelet count should be more than 70,000. And the fibrinogen should be more than 200 milligram per deciliter. Otherwise, the factor 7 will not act. That means it has to be given when in case of massive blood loss after correcting these parameters. Next. So, improving clot formation, what you can give FFP, cryo, fibrinogen, prothrombin concentrate. Prothrombin concentrate is helpful in cases of particularly liver disorders, because you have an extrinsic and intrinsic factor in coagulation, and in liver problem, it is the extrinsic factor. And you will find in liver diseases, the PT is prolonged. The PT will be prolonged and INR will be very high. It will be 4, 4.5 like that. Whereas if it is intrinsic, it is APDT prolonged. Okay, and INR will not be very high. Okay, in those cases, as the liver is not functioning, you can give prothrombin concentrate. You get 3 and 4 also, where you have factor 7, factor 8, factor 2, and one more factor is there. And yes, correction of coagulopathy. Okay, and tranexamic acid will help in decreasing the clot dissolution. Next. And avoid the lethal triad. So, massive blood loss, IV fluids first. Acidosis should not be there. Hypothermia should be prevented, and coagulopathy should be prevented. So to prevent that, you will have to give blood, limit crystallites, give tranexamic, stop the bleeding. Okay. And exposure, keep the patient warm. Okay. IV fluids also should be, you can warm it before giving and limit the IV fluid. So if you, whatever it is, our basic of management is you control the PPH, and in case of massive, see to it that we do not reach the stage of lethal triad. Next. I think that is the last slide. So the key takeaway points are PPH is most common but avoidable cause of maternal death worldwide. Every woman is at risk of PPH, though some are at greater risk. Active management of third stage should be universally practiced to avoid PPH. Too little and too late is the cause of mortality. That is too little uterotonics, blood and fluid replacement, late diagnosis, call to the senior if it is given late or if the help arrives late, and the decision for surgical management to arrest the bleeding. So decision for hysterectomy should be taken in time, and a second experienced surgeon should be involved in decision making. Sooner the resuscitation starts, more are the chances of survival. You know, there are FIGO guidelines of 2023 where there is a damage control resuscitation and damage control surgery is given, because you know you have to act fast to see to it that we have to see the mother is not going in for that triad. Next. Thank you very much, and I'm sorry for the inconvenience as my laptop was not working properly. So I thought I should share with all the recent things whatever was there in the management of PPH. Thank you.
Thank you, ma'am. That was a wonderful talk.
Thank you, madam, very much.
It is so much of good points, ma'am. This fibrinogen.
Thank you very much, ma'am.
Yeah.
Excellent talk.
Yeah. I want
Hello?
the persons to pass on the comments.
Hello. Good evening, madam. I am
Ma'am is
Dr. Uma
synonymous with
Deshmukh.
PPH.
Yeah.
Yes,
Sumaya.
Sumaya.
Ma'am, yeah, the excellent talk, ma'am. It's such a pleasure always to listen to you on PPH. Every time we learn something new. And ma'am is synonymous with PPH. Since I think many years she has been crusading this, creating awareness about PPH. So she's a pioneer kind of as far as creating awareness about PPH among gynecologists is concerned. And she's very well known for this in the Foxy circles. It is indeed a pleasure to listen to you, ma'am. Thank you very much for the excellent talk.
Thank you, madam. Thank you very much. All the time you are motivating E-motive and anti-shock government.
Srilata.
Yeah, I think
madam.
BLD is a very busy institute. Dr. Shailaja, you should have fibrinogen with you.
Correct.
You get
ma'am.
all
Recently
complicated
we discussed
cases.
this
And
really.
I know that, yes, you are using it, I believe.
Okay. We are
Yes,
getting from
madam.
Solapur. Now we are making arrangement in our hospital only. Because all referral hospitals is ours only.
Thank you.
Tertiary cases. Thank you, madam.
Madam,
Nice meeting you. Nice. It
Yes.
is very much elaborated and very good talk.
Thank you. Srilata.
Nice feedback, madam. Actually, yeah, madam. Hello, I'm Dr. Srilata from Jagityal, madam. I'm here, the General Secretary of the Jagityal Society. Madam, it's really an excellent talk, madam. After this many years, and we are going through the factors, all the factors, the requirement, and each and every detail. And madam, we have a request, madam. Can we contact in case of any emergency so that you will really help us, madam? Because really that's the time.
Yeah, definitely. Please share my number.
Yeah, madam. Actually, that's the crisis.
That is happening in Karnataka now.
Yeah, madam. Nothing strikes to our mind at that time, madam. In the panicky situation, really nothing strikes. But can we definitely can we approach you, madam? Can we give will you be available, madam? Yeah,
Definitely. I'm always there.
Yeah,
Yes.
and that's actually this is more beautiful than that. All the talk. Yeah. And thanks, madam.
Lata and Uma are there?
Hello, madam.
Yeah.
Madam, good evening. And really, the Sheila madam is a master in PPH. We can call her queen or mother of this subject. And really, it was very nice, madam. Recent advances also I have told. And we are planning here also with Sheila madam in Bidar, one PPH workshop.
Yeah. Yeah.
It's very nice, madam.
Thank you. Thank you.
Yeah. Thank you.
And
Thank you.
even our Harsh Gupta sir, principal secretary, he always he takes help of Sheila madam, and for to train every gynecologist in health and family welfare, even medical colleges and periphery doctors. Really, hats off to you, madam.
Yeah, I still remember the way the condom tamponade, the cut the end and invert the condoms like
Yes,
that.
yes. With that catheter and condom,
Yeah,
no? And
yeah. In
even that
age,
one workshop was there with the Singapore team. The madam was also the main person was there to train the.
as you correctly said, PPH and synonymous with the ma'am. That's
Yes,
all.
yes. King,
Thank you.
queen, or mother.
Lata is
Yes.
it? Dr.
Thank
Lata,
you, ma'am.
Chitradurga? Yeah, and Mangla
Thank
ma'am
you.
is come back.
I'm really overwhelmed with your responses. And Dr. Srilata, you can take my number from Dr. Vijaya.
Yes, ma'am.
Okay.
Yeah.
And
yes,
if you want me to do a webinar for Jagatiyar Society, we can do it.
Definitely, madam. I'll try to arrange one webinar. Yeah, this will be really a very useful thing, actually.
Thank you. Thank you so much,
Okay.
ma'am. Thank you for amidst a busy schedule. I know how difficult to get you. I was constantly calling her daily. So nice, ma'am. PGs are really benefited. All the PGs from Chennai MMC have joined and they are all listening to you. It's a great educational thing for them. Especially the PPH is a commonly asked question both in the clinics and in the exam, ma'am. Thank you so much, ma'am. Yeah. Yes, Sagiti.
I happened to meet Dr. Iyer recently in who is the one who proposed a garment in Tamil Nadu. And he was Dr. Iyer. You may not know, very senior person, Dr. Iyer,
Yes,
who
madam.
brought anti-shock. So I met him in Ooty. Yeah, anti-shock garment. Madam, you have taken up that. So very happy to meet him in Ooty. Thank you, Vijaya.
Thank
It was
you, ma'am.
nice, and I wish you all the best once. Yeah.
Thank you, all the
Okay.
chairpersons for the session.
Yeah, and I request all the South society see to it that people South India are trying to come forward, because they are not very received. We always, but now everybody is gaining interest and coming forward. So I think all of us have to really support each other.
Yes,
Yeah.
ma'am.
Okay.
Thank you, madam. Thank
Yeah.
you so much. Can we move on to the next session? This is a very, very interesting session.
Thank you, Sahitya.
Yes, madam. Sagiti.
Thank you, ma'am.
Yeah. The screening of the CS cervix and the chairpersons for this session are Dr. Sumitra. Can we have the CV? Yeah, madam is Professor HOD, MG, MMC and MTH Hospital. 33 years of teaching experience and she's a secretary of IOGS in 2020 and president of Indo Society 2024. Lot of awards for madam and also from Young Scientist Award, and she is the chairman of the MDSR committee, Indo division, expert member in PCPNDT and ART regulation and district committee. Welcome, Dr. Sumitra, ma'am. Next slide. Dr. Sunita is the president of Ratlam OG Society and she's the director of Ratlam Hospital and she's an NABH assessor and she's done her MBA in hospital and healthcare, lead assessor in Manyata and master trainer in Manyata by Foxy. Welcome, Sunita. Dr. Batmani is from Osmania Medical College. She's done from MD, MBBS from Osmania, MD from Gandhi Medical College, previous Foxy president of Karim Nagar, past president of Jajital IMA, and founder president of Jajital and private practice for the past 39 years. And welcome, Dr. Batmani. Next slide, please. Dr. Sunita is a gynecologist and infertility specialist and lab surgeon from Indore. She is a secretary of Indore OG Society and she is a lifetime member of ISAR, IMA and Menopausal Society, examiner of FMAS exam in Ujjain, core team of the organizing committee 2022 Indore ACOG, treasurer of vice president conference 2023 and special interest in gynae laparoscopy surgery. Welcome, Dr. Sunita. Dr. Nidhi. And she's the endogynac and OBGYN, infertility specialist, and she's the director Spash Hospital, Katni, and she's the secretary of Katni OG Society, and she has publications of term uterus and complicated mental hernia in Jepigo, and she's a member of Oxy, COGS, and PCO Society, and she has social activities, hysterectomy camp in Rajasthan, lab and fertility enhancement camp in Ranchi, and she has got a Young Talent Award, West Zone in UA Foxy 2022. Welcome, Niti. And Dr. Aditi, she's a consultant at Ratu Nursing Home. She's an MS OBG, executive PG program in healthcare management, secretary of Ratlam OG Society, and faculty in national and state conferences, and received PMSMA award. Welcome, Aditi. Yeah, our speaker. Can one of you introduce Sunita, ma'am? Can you introduce Dr. Shruti? Your slide is seen.
Very good evening to each and everyone. Can you hear me?
Yes, ma'am.
Yeah. It is my pleasure. Thank you very much, Dr. Vidya, for taking me as a part of this beautiful webinar. And we had a real, beautiful lecture on PPH. So thank you for the same. It is my pleasure to introduce Dr. Shruti Najudappan. She is a consultant gynec oncologist in PSG Institute of Oncology, Coimbatore. Dr. Shruti has done MCH gynec oncology at Amrita Institute and senior resident at Kidwai Cancer Institute, Bangalore, assistant professor at Aditya Cancer Institute, Chennai, observer Christie Hospital in UK, best outgoing fellow in FAC RIS 2024 Delhi, best poster award in robotic surgery at FARIS Conclave Delhi 2024, travel grant in robotic observership on UK awarded by Ferris, and Vaticute Scholarship, Robotic Surgeon Council of India, Pondicherry, PSG Prime Grant Project in Endometrium, ICMR funded project of COPI, Gynec Oncology Coordinator for Preventing Oncology, Screening and HPV Vaccination Program, PSG, member of AGRS, ARIS, IAPC Certificate Consultant. Welcome, Dr. Shruti.
Thank you, ma'am. Thank you, Sunita, madam, for the lovely introduction. Then I would like to thank personally Vijaya, madam, and congratulations and all the best, madam, for your candidature for your chairperson in Foxy Medical Educational Committee, and co-convener Dr. Madhupriya. Madhupriya and I, we have a long way to go when we worked many years back with Dr. Meenakshi Sundaram. And also, I would like to thank all the chairpersons of the meeting today. Sumitra Madam, Sunita Madam, Padmini Madam, Sunita Chauhan Madam, Nidhi Bajaj, and Aditi Rathur. So the topic given to me is screening for CA cervix. I'm just sharing my screen. Let me know if you can see it, madam.
Not yet, Shruti. Yeah.
Just sharing, ma'am. 1 second, give me 1 second. Ma'am, is it visible now?
Yeah. Very much.
Okay, ma'am. I'm just going to. Okay, ma'am. Right, I'm just starting my PPT. And thanks for the lovely introduction, madam.
Thank you very much.
And so today we're seeing about the pre-malignant lesions of cervix and its management. It's a very big topic, so we just try and cover as much as possible in whatever time is possible. So this is what we are going to see today, and a little bit we'll be touching about CIN in pregnancy as well. So this is the post. This is an Insta post which the WHO organization had shared, and regarding elimination of cervical cancer with HPV vaccination program and also HPV screening. And all of us know, going to this topic, the transformation zone. So this is the region where almost all the pre-malignant and the invasive disease of the cervix arise. So visualization is very important. And the transformation zones, squamo-columnar junction migration with age, in every age group, premenarchal, after puberty, early reproductive age, women in 30s up till postmenopausal. Now, coming to the definition of CIN, so basically, cervical intraepithelial neoplasia is abnormal growth of squamous cell on the surface of the cervix. And per se, CIN1 is not a precursor lesion, and mostly they regress within 5 years. Whereas CIN3 is definitely the true precursor of CA cervix. Now, going to the classification, we do have the Bethesda classification, the CIN system, and also the Papanicolo system. And the Bethesda classification, we classify into ascus, ASCH, LCIL, HCIL, and squamous cell carcinoma. And then this is the last terminology. So the last is classification is lower anogenital squamous terminology. This is basically, this unifies the two-tier terminology. So instead of having too many classifications, they just classify into LCIL and HCIL, where LCIL is CIN1, all cases of CIN1 with P16 negative SIN2, and HCIL is SIN3 with P16 positive SIN2. Now, looking at the global burden of HPV infection is, you can see the orange, all the orange are all very high risk, high prevalence, high incidence groups, and definitely India, Africa, South America, all of us top in this range. This is our own Indian statistics. So LCIL and SIN1 is almost 30%, and HCIL, SIN3 is 60%. In total cervical cancer, the burden is about 84%. Coming to the regression, persistent, and progression. Now, this is what is important, because if you see CIN1, the regression is almost 60%, whereas the regression in CIN3 is half of it, is only 30%. And then the progression to invasive cancer, CIN1, SIN1 is 1%, whereas SIN3 is almost 12%. And then the natural history, if you take ascus, just very similar to SIN1 and SIN3, ascus and HCIL. Ascus is almost, the regression is about 70%, and half of it is HCIL. The regression is about 35%. And progression to invasive cancer is ascus and LCIL is very low risk, less than 0.5 percentage, whereas HCIL is slightly lower, about 1.5 percentage. Going to the HPV pathophysiology, HPV is mostly cleared 93% by 3 years. Now, there is this persistence of HPV infection which causes LCIL, and HCIL is because of progression. Again, from HCIL they can regress, but then again, because of precursors, they can go on to have invasive carcinoma. Now, this is the most important slide. So basically, this is a slide which will tell you where your vaccine, at which level vaccine works, and the difference between your basically prophylactic vaccination and therapeutic vaccination. So prophylactic vaccination is given when your cervix is normal, even before the HPV infection starts. From 9 to 15 years at adolescents, young adolescents, where we vaccinate. Now, therapeutic vaccination is in patients who already have a HCIL, SIN3. You will give therapeutic HPV vaccination. Going to the screening modalities. So coming to the screening modalities next, if you see, we have the cytology, which is the conventional PAP and the liquid-based cytology. We have the VIA, villi, and HPV screening, and basically a co-testing, which is cytology with your HPV DNA testing. And of course, we have the special biomarkers. Biomarkers is they detect the high risk HPV, which is by mRNA detection, the P16 training, the P16 staining, and of course the markers of proliferation, which is your Ki67, MYC, telomerase, MCM2, TOPA, T2. HPV, it is a double-stranded DNA virus, and you have about 15 high-risk types and low-risk types. Out of the high-risk types, HPV 16 and 18 account for majority cervical cancer, and low-risk type HPV 6 and 11, they account for 90% of the genital warts. HPV oncogenesis, yes, Nobel Prize was awarded to Zerhausen for isolating the oncogenic HPV strains and describing and elucidating the oncogenic process in cervical cancer. So going to the mechanism of transmission and acquisition, basically it is through sexual contact, and also proper condom usage may reduce the risk but is not fully protected against the infection. And non-sexual is mother to the newborn, which is basically vertical transmission, and fomites is basically hypothesized, but it is not well documented. We can tell it is very, very, very and extremely rare. Now, what are your determinants of HPV infection in men and women? Women is young age, sexual promiscuity, number of sexual partners, age of first intercourse, smoking, then genital tract infection, immunocompromised status, uncircumcised male partners, whereas in men, it is almost the same. So, establish and potential cofactors, again, we've seen just now high parity smoking, HIV, then co-infection with sexually transmitted infection, diet, hormones, and genetic factors which predispose to HPV, thereby the persistent infection causing cervical cancer. Now, the importance of HPV testing. Now, how did this come? Where did all of this start? This was in about the 1990s when HPV DNA was detected in almost all the cases, about 99.7% of all patients with cervical cancer. In their biopsy, this HPV DNA was isolated, and this was conducted across 22 countries. And from India, this is by Nirja Batla and et al. So this was in her vaccination papers, where they have again isolated about 96% of women with cervical cancer and 86% of women with HSIL were tested positive for HPV. And again in the rural Western India by Deodhar et al. Again 94% and 84% of HCLs were positive for HPV in rural Western India. Now, going to the testing techniques. So, we do have the HPV DNA testing techniques. Basically, two techniques. One is your rapid non-amplification techniques. Basically, you have your nucleic acid probe test. So, this is very easy, like your ELISA test, which is available. And next is your amplification techniques. So amplification techniques are basically PCR based, which is your target amplification, and signal amplification. Signal amplification includes hybrid capture, cervista, and probe amplification is your LCR, which is a ligase chain reaction. And what we commonly use is a target and signal amplification test. Now, this chart is to tell you what is commonly done, and between the different tests of HPV DNA testing, what they do, the mechanism, what type it is. So your hybrid capture, Cervista, COBOS, basically what are the genotypes tested, and the sensitivity specificity in all is almost about 90%, and the availability in India, the cross reactivity. So this is just a classification to tell us regarding what is the some amount of difference in each test. So going to the self-sampling versus clinician collected samples. So now we've been hearing a lot about self-collection, self-sampling, HPV DNA sampling. So now there are many studies which were conducted, and out of which they said definitely the sensitivity and specificity of a clinician collected specimen is definitely going to be higher than a self-testing. But what the difference was, they've noticed that when signal amplification test was used, and there was a significant difference rather than when it was a PCR based test. So signal amplification tests are much slightly better than a PCR base is what they have proposed in the study they have conducted. And definitely the compliance is better. And then they did miss a few high grade disease, but it was not statistically significant. And then this is the study which was conducted. So regarding self-sampling, and the study which was conducted in India, what they found out is it's a relatively rapid, affordable HPV self-test kit can be used, and this is especially useful in low resource situation. So self HPV sampling compares favorably with physician sampling and cytology is what they found in the study they have conducted here. And going to the proposed paradigm about how to start about HPV as a starting point. So in general, when we see all the guidelines, HPV testing is recommended after the age of 30. So the starting age is 30 till 65. So HPV test is negative. Yes, you have a 5-year recall period, and if it is positive, we do a reflex testing with the cytology. And then if that is positive, we have to repeat a test call them for a repeat test in 1 year or subject them to colposcopy subsequently. So the clinical utility of HPV. So how do we go about, and so where have we started from and where are we here? So the main utility, if you see, now this is the preferred method for primary screening as well as this is used for co-testing. And the main important thing here is HPV in the management of women with ascus cytology, ascus positive cytology, to triage them for colposcopy. This definitely HPV is a very important tool. And then following the treatment of CIN, CIN and HPV testing is more sensitive. And then this most important point is what we were trying to tell, that HPV self testing kits, they have been introduced because when you have a cytology, whether it is going to be LBC collection and going to a pathologist and all that is going to be very difficult. But whereas the HPV DNA testing, you have rapid testing, and this is very, very much easier and very easy in places, especially sub-Saharan Africa with very less infrastructure. And you don't need actual cytology labs or the pathologist to do the test or to read the test result. So now going to the cytology. Now we have different methods of collecting the smear. We have different brushes and spatulas. So we use a traditional spatula. We have to rotate once or twice, and with the endocervical brush is a quarter rotation. And generally the broom you use, it will be about 3 to 5 turns rotation. And then the different types of preparation, you will have to, if it is a thin prep, then you will have to nicely put your brush in and shake the bottle. And if it is going to be a sure path, you will have to break the brush. And in HPV is you will have to at least 3 to 5 times, you will have to rotate counterclockwise and snap and break the brush. Now going next to the satisfactory smear. Now, what is a satisfactory smear? To actually call a smear satisfactory, you need a minimum of 8,000 to 12,000 well-preserved squamous cells in a conventional cytology, whereas 5,000 cells is adequate in a LBC, liquid-based cytology. And then at least 10 well-preserved endocervical or squamous metaplastic cells will need to be there. And adequate specimen preservation and fixation is very important. Now going to the difference, the comparative difference between LBC versus conventional. Now how LBC is useful is, as we have seen, the unsatisfactory results are slightly lower in LBC than compared to your conventional PAP. And definitely now you have same containers where you can use the same container for your LBC and use the same container for HPV also. So if it comes positive, you have the same container solution, you can always do a reflex testing is possible. Only thing is it's a higher cost. But then when you compare as such, what is the difference, the sensitivity or specificity? There is it is neither, both are almost very similar. There is nothing like, LBC is superior than PAP. When it comes to sensitivity and specificity, both are actually the same. So now going to the other testing methods, we do have our VIA. VIA is an absolutely beneficial, and it is a very sensitive test, sensitive to, it's in fact its sensitivity is comparative to the pap smear. Only thing is it's low specificity, and definitely it is used in low resource setting. And then we do have the villi. So again, villi is we have the mahogany color which stains, and depending on the stain you can call it. And just like your VIA, villi, these are all very useful methods of testing. Now going to this, a single visit approach for the management. Now there was a paper which was here conducted. Now the conclusion is that there were many conclusions, but one important aspect of this paper is, if you see the test which was conducted here, the sensitivity of VIA and villi is comparable to that of the cytology which we use. And it is best used, VIA villi is very useful for the single visit screen and treat approach, and to in low resource setting, as well as you can guide patient for ablative and excisional therapy. And coming to the accuracy of a screening test, as we already said, the sensitivity of the VIA and cytology is something we will have to see, and HPV testing is definitely more sensitive. There were 3 trials which was the most famous, the ALTS, the Tambola and Athena trial. So this ALTS trial is what we spoke about just now, because ATLS trial, the end result of this trial is HPV testing is useful in triaging patients who are ASCUS positive. So to triage them for colposcopy, there comes, we can use HPV DNA as a test guide. And next is your Tambola trial. So Tambola trial is your cytological surveillance versus colposcopy. So whether HPV testing will add any benefit to your cytology surveillance and colposcopy, it was found that there's no added benefit, especially in women less than 40, but it is definitely useful in older women. Now Athena trial. So Athena trial is nothing but the genotyping of your high risk HPV, your 16 and 18. And then this is indicated only for HPV positive cases with the negative cytology, is what they have found from this trial. So going to the use of primary HPV testing as a cervical cancer screening, and in April 2014, this was released. The FDA has approved HPV as a screening, as a primary screening method for women. And then this is not to be initiated prior 25 years of age. And then biomarkers. Now, next going to biomarkers. Now, what are these biomarkers and why are these important? We know they are definitely very expensive. Now, what does make these biomarkers special is, see, you're basically your HPV testing, they cannot distinguish between whether it is going to be a transient infection or is it going to be a persisting, or whether it is going to transform through a malignancy, whether it has the transforming potential. And majority, if you see, all your HPV, your persistent HPV will clear away within 15 months. So that is why they say, if it is HPV positive, you call back and do a testing in 1 year, do a repeat HPV testing. Now these biomarkers, what they do is, they will differentiate and they will tell you if they are transient infection or they are the persisting high potential transforming infection. Now these biomarkers are your E6, E7, HPV mRNA transcripts, cellular oncoproteins, especially your P16, P16-INK4A gene. So this is what is linked to your the first slide we saw. And then the E6 oncoprotein, MCM2, TOPO2A. Now, this is what we will have to remember. Now, if you see this slide, where a pap smear, all our cytology acts is, if you see, the precancerous lesion to the invasion. So that is where your pap and everything acts. And now when you are going to do a simple HPV DNA testing, you see where your cervista, hybrid capture and everything. So this will just tell you if it is there or not. But then your progression and regression. Now this is what your oncoproteins and all these testing are actually going to diagnose and tell you whether they are going to go to a precancerous lesion or they are going to go to a cancer lesion per se. So that is where your Aptima, your Avantage strip test and all your oncoproteins, they play a role here. And as we've already seen, P16-INK4A, This is this is definitely useful in triage of LCIL, then ASCUS over HPV DNA. So this is what we've seen in our last terminology. And definitely, if you have a P16 positive in a SIN1, we know this she is going to land up in a SIN3 very shortly. Now, what are the tests to detect the biomarkers? As we've already seen, you have special biomarkers here: E16, E7 oncoproteins, HPV protein, P16, INC4A, P67. So this is just, how you use. This is used as an adjunct, as I told you. You have a primary HPV testing done, and you'd like to see whether they are going to be automatically cleared of the infection or they are going to persist. So that is why it is used as an adjuvant to primary HPV testing. So these are the different manufacturers, and what is the sensitivity and specificity across. Next is your screening guidelines. Moving on to the next topic, screening guidelines. So ACOG and ACCP guidelines is, when do you start? Yes, more than 21 years, and when to stop is 65 years. And definitely HPV testing is advocated after 30 years, whereas your cytology is started from 21 years of age. And if you do cytology alone, when do you repeat? If it is a negative test, is 3 yearly. Whereas if you do a co-testing, then if once it is negative, you can do it 5 yearly. And adequate negative. Now, what is this adequate negative is when you have a 3 consecutive negative cytology result or 2 consecutive negative co-testing results within the previous 10 years, with the most recent test performed within the past 5 years, after which you can exit the individual from screening. Now, this is our own guidelines. This is a pilot project conducted as a pilot project in Tamil Nadu. So all women more than 30 years, and the method of screening was used here was VIA. So then next, moving on to the follow-up and management of screen positive patients. This we have already seen the progression and what is the follow-up protocol. So this is screening and management algorithm. We'll quickly rush through this. So is she VIA positive? Then what you do? VIA positive, you take a biopsy, either colposcopy directed. She is eligible, you go in for a cryotherapy. If she's SIN1 cryotherapy, more than that, you go in for a leap. Okay. Now, this is the ASCO Resource Stratified Clinical Practice Guidelines, the American Society of Clinical Oncology. This is very similar to our guidelines. The only thing which is which they have extra, they have quoted is special population screening. As in, when a HIV positive or immunosuppressed individual uh, comes, you will have to screen with HPV as soon as they are diagnosed with HIV positive, and they screen twice and many times they want in a lifetime as a general population. And the primary screening is usually from 6 weeks to 6 months postpartum is what the ASCO resource stratification guidelines have proposed. And then there's a WHO decision-making flow chart for screen and treat strategies. So then if you have a HPV or cytology, what you do, if it is positive, then you go ahead with your colposcopy. And then depending on what it is, and then you can go with a cryotherapy or a LEAP. So you must have a ready cryo or LEAP must be part of your screen and treat program. Again, using HPV as your primary testing system, as we've already seen, HPV positive or negative, you do a reflex cytology, and then you get an ASCUS. What do? You direct them ASCUS, or you direct them to a colposcopy, and then you treat accordingly. This is the co-testing, which is what we've been talking all this while. And VIA, yes, VIA positive or negative. Positive, you do a colposcopy and biopsy and treat according to the guidelines. ASCUS in women aged from 30 to 64 years. So this is where HPV testing is very important. In ASCUS, you do a HPV. If they are positive, you guide them to colposcopy. So this is again management of ASCUS H and HCIL. So this, what you will have to do is either ablation, leap ablation, or diagnostic excision if you cannot see a transition zone not completely visualized, and you have to manage according to your GCPR guidelines. Again, management of LCIL. Again, colposcopy biopsy is positive. You manage them according to GCPR guidelines. And of course, you have abnormal glandular cells. You will have to rule out whether it is from endocervical or endometrial or ovarian. You will definitely have to do a endocervical and endometrial curettage and find out where it is from. So next, moving on to our colposcopy. So colposcopy, the main thing of colposcopy is magnification, and the magnification we use is about the mid-zone level, where we usually use in the highest magnification is about 20 to 30x. And we have the green filter, the which enhances the vasculature, and saline will help us in visualizing the blood vessels and leukoplakia. For hemostasis, when we do a biopsy, we can use a Monson solution or a ferric nitride. We have two scoring systems. One is a read, where we have points for each grading, and till 4 points is a low risk, where it is CIN 1 to 2. More than 5 is definitely a little high risk. And then we have sweet score. So similar to that, we have a scoring pattern, where less than 4 is benign, and more than 5 to 7 is a high grade lesion. More than 8 is definitely she's a candidate for C and treat. Now, going to the treatment modalities, where we can have ablative and your excisional modalities we can have. So ablative is your cryosurgery, cold coagulation, CO2 laser, electrothermy. And the limitations are, if adenocarcinoma in situ suspected, or you have a glandular lesion and a colposcopy has invasive disease, you should not use this technically. And excisional is going to the excisional procedures. You have the excisional biopsy, conization, cold knife cone, CO2 cone, and your loop procedures and surgery as well. So the main thing is the lesion should be entirely visible and not occupy more than 2 quadrants of the cervix for ablative procedure, and the entire cervix should be localized, and the lesion should be adequately covered by the largest cryotherapy probe available, and should be no suspicion of invasive cancer. And definitely screen and treat by cryotherapy is contraindicated in specific cases, especially if she has a postcoital bleeding or a postmenopausal lady, or whenever you see an obvious growth on the cervix. So going to cryotherapy, yes, cryotherapy is it basically acts by crystallization of intracellular water, and you use this by a freeze thaw, freeze defrost technique, and nitrous oxide is used. The depth of infiltration is about 5 mm, and it's painless. No anesthesia is required. And if you see the advantages, it's a day procedure, no major expertise. You can repeat it many number of times you want. And disadvantages is, yes, patients do complain of a repeated watery discharge, and they do have a crampy sensation, especially for the first 24 to 48 hours. And there is about 3% of the cases report for cervical stenosis. An indication is low grade lesion confined to the ectocervix, and there is no microinvasion on colposcopy, cytology, or an ECC, endocervical curettage. Now, WHO 2010 cryotherapy guidelines is, now cryotherapy is preferred over no treatment, definitely. Whereas when LEAP and LEDs are preferred when available and accessible, and carbon dioxide is preferred over nitrous oxide, and the double freeze technique is preferred over the single freeze cryotherapy, and lesion covering more than 75% of ectocervix, or lesion extending beyond the probe, excisional procedure is advised. And lead preferred for endocervical extension, wherever you have a cryo failure or there is a recurrence with your post cryo. Antibiotics are not recommended and differ until after pregnancy. Now, going to thermal ablation, so this is what we use. I have this Liger thermocoagulator here in our unit. It's very easy to handle. It's a low cost procedure, no anesthesia, and this is used in indication CIN1, CIN2, and all type 1 transformation zone, but there should be no suspicion of cancer, glandular involvement, previous treatment, or uncertainty of grade. Going to the cold coagulation, you have the Teflon coated thermophobes, where the depth is about 4 mm is ablated, and then a local analgesia may be required for this cold coagulation, and it is relatively cheap. So then looking at the studies and the data that we have here, cold coagulation CIN cure rates were compatible to those of the other excisional ablative methods. So it is a safe and quick process and definitely used in low research setting. Now coming to an laser ablation, now where this laser ablation is useful, only thing is it is expensive, and where this is useful is especially when there is a fish mouth cervix or with a deep cleft, and when you have a satellite lesion in the vagina, definitely your laser ablation is very useful. It is safe and well tolerated. And then going on to your leap and loop electrosurgical excisional procedures, yes, it is electrosurgery. So you do have different dimensions of your leap, your high watt power which you use, and plus a small wire loop uh, which you can use. And indications are usually CIN confirmed by histology and the CIN lesions which extends into the endocervical canal. And then you have your single pass method and a multiple pass method. So single pass method is in a loop wider than the lesions. When the transformation zone to be removed should be useful ideally, and you have the multiple pass technique. If it exceeds, like if the diameter is the lesion is big and your diameter of the loop is small, and then you need to do this multiple pass method. Now, advantages is major advantage is both diagnostic and therapeutic, and contraindications, as we've already seen, whenever you have an evidence of invasive cancer or in pregnancy. And the complications is yes, they say there's an increased risk of preterm deliveries. Going to the conization techniques, we do a lot of conizations here, and I basically prefer a cold knife with a top hat conization technique, and I also use a cautery along with that. The cautery which I use is a tip cautery. There is something called the pin tip cautery, which is nice, and which just act like your knife. It's a big top hat, and basically conization we do it both. We see to that it is both therapeutic as well as diagnostic. And where conization actually helps is when there is a lot of discrepancy between the cytology, biopsy, colposcopy, and then when you have the cytology which shows atypical glandular cells, but your biopsy or ECC you don't get anything. And then when there is adenocarcinoma in situ, and you need to go ahead and establish invasion to go ahead and do the radical hysterectomy on a patient or fertility preservation or manage accordingly, that is where this really comes in handy. So this is what I said, cone biopsy. But only thing is primary, secondary hemorrhage is more, and definitely cervical incompetence, and depth of the cone should not be more than 1 centimeter. Then you have the nets, the needle excision of transformation zone. Now, the one advantage is that it yields a one-piece cone specimen, and preserving, what it does is basically it just comes out in one form and preserves the orientation of the specimen. You need not, whenever you take a cone, you need to sit and mark an orientation, long lateral, short superior, or tall short, and with your suture you need to take. But this basically does not need any orientation. Now again, going on to management of sin, which this is already we've seen, and what we should do, how you should do. So going on to an unsatisfactory cytology, what you have to do, you have to repeat and triage with HPV. So this we've already seen, ASCUS and cytology, LSIL. So this is nothing but your all our ASCCP guidelines. How you manage them, what do you do with your co-testing and colposcopy, how it is done, when it is done, and what do you do accordingly. So this we've already seen as sketch is on a colposcopy. You have to manage as per your guidelines whenever you have this report of as sketch and HCL also. Now, SIN2 is found at colposcopy in 60% of HCL. So that is why you will have to do an immediate excision. So that you don't lose the patient to have to follow up. AGC, which you've already seen, you will have to find out where the primary pathology is. Is it in the endocervix or is it in the endometrial? And 5% to 10% can also have the ovarian primary, fallopian tubal primary, which that also will have to be checked. So this is a no lesion or biopsy confirmed SIN1 preceded by lesser abnormalities. This we were just talking. So biopsy confirmed, how we treat. This is all our ASCCP guidelines, how we do, what we do. Basically, everything is the same principle. When you do colposcopy, when you do pap smear, when you do a cytology, and then you do a reflex testing, and then comes your HPV, and then when you subject them to colposcopy, do a biopsy, and what comes, and then you manage them accordingly to all the techniques that we've described. And adenocarcinoma in situ, definitely yes, as we've already seen. So this is what I said, when it is a in situ, it is better to do a therapeutic cone. So therapeutic cone, if you do, the margins are negative, so that is the treatment for a patient. This helps actually in fertility preservation, young patients who are looking forward for pregnancy. So this is the general summary of all that we've seen. So cytology, yes, the next step what we do is when you have a cytology positive, and then when you have an ascus, you will have to do them HPV triage, LSIL, HSIL, everything. You do a colposcopy. HSIL is a colposcopy along with colposcopy leap in the same sitting. And then the AGS, yes, you have a glandular, as we told you, you'll have to rule out an ECC or an is it endometrial aspiration or endocervical curettage. That definitely has to be done. Now surgery, there is no clear-cut evidence to show that one optimal surgical technique is superior for treating precancerous cervix anomalies. And we're just going to touch about CIN in pregnancy. So the incidence, if you see, the cervical cancerous pregnancy is 1 per 1,000 live births, and the prevalence of pap smear in pregnancy is around less than 10%. Now, the management is ascus. LSIL is very similar. You wait 6 weeks postpartum. And diagnosis, when you do all your excisional procedures are recommended only if an invasion is suspected. Otherwise, you will have to repeat after 6 weeks postpartum. So that's it. So colposcopy in pregnancy it's very difficult to diagnose and manage. It's very easily said than done, because there is a lot of edema, there's a lot of vasodilatation, desudalization. So usually the cervix appears densely aceto-white. So that's a difficulty, and this is the last part of my slide. So take home message. And persistent infection, so that is why all our oncoproteins and our special proteins are very important. That is where it comes here. That is infection. The persistent infection of HPV is essential for progression to carcinoma. Then high quality screening programs can decrease definitely the incidence of cancer cervix, and co-testing is preferred over cytology for screening above 30 years of age. Primary HPV testing can be used as screening even above 25 years of age. And our MOHFW recommends Vijaya as screening, and at least once in a lifetime screening at 35 age must be done. And biomarkers, as we've seen, is especially useful for triad screening, and colposcopy is definitely indicated if it is a HPV positive cytology ASCH or higher. And the cold knife conization is preferable over leap if it is a confirmed adenocarcinoma in situ. And excisional treatment will increase the risk of preterm delivery, and cone depth is preferably kept less than 1 millimeter. And colposcopy in pregnancy is better to do 6 weeks postpartum. So that is the end of the slide. So thank you so much, everyone, for this opportunity. And I know it is a very vast topic and a very dry topic to be discussed at the end of this day. If there are any questions, then we will discuss. Thank you, ma'am.
Switch on your video, Shruti. Video is not on.
1 second, madam. 1 second.
Thank you, Shruti, for such a wonderful. I know this GCPR guidelines. So when you read, you feel you understand everything, and the next minute it is so confusing. And finally, we are with HPV colposcopy, and then see and treat, and screen and treat. That is the way we learn. And for even students who write in the exam with GCPR guidelines, it's really little confusing. When to come back again after 1 year, after 6 months, all those things. But anyway, it's nicely you have debated, especially the molecular markers and the biomarkers, which is very important for the recent advances, and also the HPV vaccination. Yeah, the chairpersons, can you just throw some your opinion, please?
Yes, of course. I'm very pleased and very happy that she has been very succinct, very clear in her deliberation and explaining each thing very clearly. I'm very proud of you, Shruti. At such a young age, you have managed to have lot of insights. And I must admit that today in this entire webinar, I was just looking at Dr. Vijaya and looking at her smile and wondering how beautiful she is and how, I mean, this is beyond the thing, but I wanted to comment on this. I think you will be a winner because of your smile itself. I have this feeling. What a wonderful smile. All my best wishes for your winning this elections.
Thank you.
And I hope to have a long association with you.
Thank you
Thank
so
you
much.
very much.
Thank you. Sunita? Sunita Chavan, ma'am?
Yeah, it is a very nice, elaborative, and very detailed explanation by Dr. Shruti. Congratulations, Dr. Shruti. You have done a very good job. And my best wishes to Dr. Vijaya Madam for your upcoming election. This is a very informative talk. Thank you for selecting such a cases.
Thank you. Srilata? Srilata, are you there? You were there earlier. Ma'am, Sunita Vadvani, ma'am.
Yeah. First of all, I'd like to thank Dr. Vijaya for getting me here. And secondly, I like you to win this upcoming because you have been such, I mean, like as very rightly said by Vidya ma'am, like your smile is very contagious. And the presentation of Dr. Shruti was really very, very nice and very elaborate, very shortly. I mean, you covered so many things in a small 1 hour. Was very appreciable.
Thank you. Thank you, ma'am. Thank you. Thank you.
Super speciality speaks from the encore. Yeah.
It does. It does.
Any questions will be diverted to you, Shruti, because it's a little late, I think, because of
Yeah,
the
yeah. It is already very late.
yeah.
It's already
It's
9:30.
maybe whatever
Yeah.
has come, I will just message you and you can answer to them, and I will pass on. Okay.
Hello, madam.
Yeah.
Hello.
Thank you very
Yes,
much.
Srilata. Hello.
Hello.
Yeah.
I'm Dr. Padmini, madam.
Yeah, Padmini, I'm not seeing you only. So click on your video.
Yeah, 1 second, madam. 1 second. I can, I just muted. That's all. 1 second. Yeah, video.
Yes, yeah. Seen.
Yeah. Thank you, madam. Thank you for involving all of us in this webinar. And I expect you a grand success in the coming elections.
Thank
And
you.
then we have started a HPV drive program at Jagtial, madam. And then we have been doing, I have done a marathon on World Cancer Day. And then we have started in collaboration with the IMA of the Jagtial. We have started a cancer driving program. And we had a talk with the pharma people also, and we are giving the vaccine at a very subsidy price, both Sarvavac and Gardasil. And then every second Saturday in our IMA hall, Foxy Hall, we are doing that. And really, we are every second Saturday we are vaccinating around 30 to 40 young girls and the women.
Very
So
good.
yeah, this we have been doing for the past 4 months, and then Dr. Shruti has elaborated upon all the investigations, the biomarkers and all, and then how you should screen the cancer and all. But in our place, because I work in a rural area, and then it is all those biomarkers, colposcopy and all we don't do, but except for the pap smear. And I mainly feel that the vaccination drive helps the rural flock a lot because they come for the checkups at a very late stage, when already in a full blown period of the cancer cervix. And by the time we see, they'll be already in second and third stage. So, this awareness, cancer awareness, and then the drive has really, we are educating, we are going into the schools and we are going to the villages. And then, as Foxy president and IMA president in collaboration, we are educating the young adolescents and the mothers, especially. And there we are making the vaccination available at a cheaper rate. So, thank you for arranging this screening things, and then which gave a beautiful insight into the screening of the cancer cervix. And thank you once again, ma'am.
Thank you, Padmini. Srilata, I saw you with the OT dress.
Yeah.
Maybe she is going in for an emergency, I think, Srilata. That is why.
Yeah.
Okay. Anyway, thanks everyone for staying till 9:30 almost. It's 9:30. Thank you, Shruti. Srilata, would you like to have give us some comment, Srilata? Unmute.
Actually, madam, I was in a case. I had a normal delivery. I just joined. Yeah. And Dr. Padni, madam, is our president. She was telling you all these things. We were doing the
Yeah.
vaccination drive. Around
Program.
500 to 600 are vaccinated, madam, till now.
Yeah.
Yeah. Yeah. We have vaccinated around 500 to 600 people.
So good initiative, no? It's good. It's not taking up well in Tamil Nadu, especially with the IMA people. The meetings are all a little slow.
Yeah,
We really have
actually,
to.
actually, it's madam. It's all because of the Jagityal IMA and with collaboration with our Foxy Society. Na, it's running smoothly. It's people are used to this also. Every second Saturday we are putting a free vaccination camp. No, so that's why everyone is. It's passing by
They
year by
know.
year and they're coming. Yeah.
Yeah, they know it's a second Saturday means vaccination. The people should.
Yeah.
That is very good. Yeah.
So second Saturday, so everyone is got used to that, and they are also aware of that they are getting it in substrates, right? And
Very
because
good.
in 2000, actually it's 10,800 no ma'am, and now it's we are paying for 8,600. So everyone is moving forward for that.
Gardasil 9 you are putting.
Madam, yeah, Gardasil 9 and Servavac quadrivalent, madam. If they want the quadrivalent 4, we are giving the Servavac, and we are promoting the nonavalent as Gardasil, madam.
Okay. Thank you. Very nice. Everyone stayed back till 9:30. Thank you so much for accepting. I know I'm troubling all of you, but still I want to have a good webinar. Sheila Mane, I was behind madam because she's very busy, and Shruti accepted immediately. Thank you, Shruti, for such a wonderful CME. Thank you, everyone, and good night. And please vote for me.
Definitely.
Good night. Good night.
Thank
Good
you.
night, madam. Good night.
Bye,
Good
ma'am.
night.
Bye, and all the best to you.
Bye. Thank you.
Best wishes, Vijaya, madam. Best wishes, madam.
Thank you. Thank you, everyone. Thank you so much.
Thank you.
Shruti, thank you, Shruti.
Thank you, ma'am. Thank you, ma'am. Thank you so much. Bye,
Yes,
ma'am.
Sahiti, on behalf of the webinar, I would like to thank Sahiti for giving me the platform and being there with me and arranging the slides for Madam Sheila. Madam, thank you, Sahiti. Please.
And thanks a lot,
It is
Vidya.
on
And
the
thanks a lot,
YouTube.
Vidya, madam. Yeah.
Yeah,
Thanks a
thank you.
lot, Dr. Vidya. Actually, yeah, we are always ready to attend this such webinars, ma'am. Yeah.
It will be on the YouTube. You can tell all your friends. It will be immediately uploaded in the YouTube. Everybody can watch, whoever has missed it. Okay.
Okay, ma'am.
Thank you. Thank you. Thank you, Sagiti. Bye. Good night, all.